Good afternoon. Hello. To our in-person audience, I am Dr. Shauna Nesbitt, Vice President for Institutional Opportunity, and it is my great honor to welcome you today to our first lecture in the Health Disparities Research Series that we will be doing. My partner here, Dr. Omer, who is our Dean of the School of Public Health, have partnered together to produce this series that will take place over the next several months, actually each month until May, and then one that is displaced all the way to the end of the year because it's just that popular. But today we are really, really excited to have you all here to present our first lecture. To our online audience, thank you for joining us. We look forward to having a fantastic lecture with great conversation to follow. Dr. Omer, any comments?
Thank you. It's a privilege to start this lecture series and to start with Dr. Suleiman, who has done a lot of impactful work on this topic. I would say that public health and medicine are the ultimate consequentialist disciplines, meaning what we do should be and is evaluated by the number of lives we impact positively. But we also not only look at impact in aggregate, we look at impact for everyone. And so therefore, health disparities and the fact that the impact of our population and clinical interventions should get to those who need it the most is part of our core ethos, our core mission, and hence this series. And I'm very excited to welcome Dr. Suleiman as our first speaker in this series.
Thank you. A little about Dr. Suleiman. She is Associate Professor in the Department of Orthopedic Surgery and Medical Education at Northwestern University, Feinberg School of Medicine in Chicago. She specializes in minimally invasive hip and knee arthroplasty and revisions. She also serves as the Associate Dean for Diversity and Inclusion there. After completing her joint replacement fellowship at Rush University, she returned to Northwestern and went on to complete a 2-year health policy fellowship with the American Association of Hip and Knee Surgeons. Her research interests are in disparities in access and outcomes in hip and knee arthroplasty. She's currently the presidential line for the Ruth Jackson Orthopedic Society and will serve as the AAHKS Program Chair for the 2026 annual meeting. It is my honor and pleasure to present Dr. Suleiman. It's absolutely delightful. We had a lovely time at dinner last night, and she let me know that she appreciates the Dallas, what we call winter, but what she's calling summer. Dr. Suleiman.
Thank you. All right. Can everyone hear me? Wonderful. I am just absolutely honored to be here. It's warm. I wore my light winter jacket. It's been great food. I feel like I probably gained 10 pounds in the last 24 hours. But really an honor to be here as part of your lecture series, especially being the first lecturer in musculoskeletal health, which is one of the few areas that is under-resourced, underreported, and underfunded. In my role as Associate Dean for Diversity and Inclusion, my role is actually more so with faculty and the hospital system and really looking at how we've sort of created health equity and how do we innovate health equity moving forward. These are my disclosures. One pertinent to this talk is Revel AI, which I will get to a little bit later today. So whenever I talk about health equity and disparities, I really start by making some acknowledgments. I think it's important as a speaker, as someone who identifies as a cis Black woman in orthopedic surgery, is understanding the lens, the framework that I'm coming from. I carry bias like everybody in this room. And so when I give a talk about health equity, I just like to stop before we even begin to acknowledge that every single person, both in this room and in the audience, has their own framework for how they understand diverse patient populations and underserved patient populations. I truly believe that our priorities and our lens can really change over time, that we're not stagnant in how we view these topics. And much of what we cannot be changed or manipulated, but I truly believe in sharing in conversation and sharing in knowledge that there's power and opportunity. So what is health equity? I think most people in this room who are engaged in this conversation understand it's the fair and just opportunity to give everybody, every patient that we see, an equitable option in a safe and healthy environment. And where I think health equity starts with is us as physicians, healthcare providers that are interacting with patients on a day-to-day basis. And with that is understanding bias. I'm sure most of you in this room have taken an implicit association test. It's a bias testing model. People have a very negative connotation of bias. Bias is something that is naturally comes to us. It's our defense mechanism. What happens is if our bias is used in a negative pathway, if we don't understand what those biases look like. Does anyone have any guess on when we actually form bias, at what age? Throw a couple numbers out. 3. Okay, we got 3, 1-year-old, okay, 9. So why this number stands out to me is because my daughter is 5. And that's when you formally start having your own biases. And I start to think about this 5-year-old who, has sassing me up most of the time because she's a young girl, has got this bias, right? But it's your defense mechanisms, your positive and negative energies, and your experiences. When I think about bias, where we really started to understand preferences, in the U.S. really started in this 1940 doll study. This actually was done by both Kenny and Mamie Clark. They're a husband and wife couple. This actually came out of Chicago. This test in 1940 was really the test that allowed board versus education to desegregate our schools back in 1954. What they showed these very young children, 5-year-olds like my daughter, were a variety of dolls, from white to very dark skin, and all different types of shades. And overwhelmingly, whether you're a white child or a black child, they ultimately always preferred the white doll. And so this test was actually repeated in 2011. There's a great CNN special about it where they looked at this study and they redid it on kids. It was the exact same results, right? We're now almost 50 years past desegregation of our schools. So when we think about physicians, we all take our Hippocratic oath. We all vow to treat patients as the same, but does it really happen? And really why this study was done with patient-physician racial concordance, we actually just got this published last month. I've always sort of wondered in the orthopedic space, it's 96% white men in our specialty. Does our biases affect these disparities that we see on a day-to-day basis? So what we found in this study and what we did, and I really thank my partners who participated in this study. I'm the only woman in my practice. I'm the only black person in my practice, with my division, I should say. And what we looked at is 402 patients. They all came in with knee or hip pain. We filled out the American Academy of Orthopedic Surgeons guidelines to understand who was a candidate for surgery, right? We filled out the paperwork, we circled it, but we didn't score it. We actually had a blinded score with one of our research assistants score it afterwards to say, is this a patient a candidate for hip or knee replacement? Interestingly enough, patients who experienced racial concordance with their surgeon were more likely to receive a recommendation for a total knee arthroplasty. And this is despite controlling for factors that we don't do surgery on. A1C greater than 8, smoking status. This is controlling for all of those factors that we would all agree that you're not a candidate for surgery. So it makes you think, what is it about racial concordance or even gender concordance? If you know the work out of Hopkins by Lisa Fitzpatrick, she's looked a lot at gender concordance. What is it that makes care so different, right? Is it just simply looking alike? And what we find, it's actually our communication, right? It all comes down to how we're talking to patients when you're racially or gender concordant. And she highlights these communication domains with satisfaction, the amount of time I actually spend with a patient. So again, a black woman comes into my office. On average, you spend 20 more minutes with that patient. Visit length, the participatory status, how much you're engaging in your conversation. So when we sort of debriefed as a group looking at these results, it's sort of shocking. Like, no, I would of course offer surgery. You don't realize you're doing it. Because the patient may say, no, I don't want surgery, or something will trigger you into not wanting to offer surgery. But really it comes to that time you spend and how you actually deliver the information for care. So I highlight that really if we're dealing with patients, taking care of people who don't look like you, it's really important to understand what these communication domains look like. So when we look at the overall cultural competence in health communication, most of people in this room probably know about the Institute of Medicine's statement in 2003 where they saw racial and ethnic minorities tended to receive lower quality of care than non-minorities despite controlling for all of these other access factors. The ultimate solution, and this is like a 200-page document, one of the biggest factors in this study in 2003, the statement by the Institute of Medicine, was we just need to diversify medicine. We need Black people taking Black people, Latinx people taking care of Latinx people. But if I wait, I'm one of 7 Black women who are trained in hip and knee replacements in this country. 7, right? The first person was trained in 1990. That's a huge age gap. I'm going to be waiting another 100 years for more Black women to be trained in hip and knee arthroplasty. So I don't think it's a tangible solution. So we actually published this in JBJS, an updated solution specifically to hip and knee replacements. And what we find is the clinical appropriateness, the discrimination, the bias, and the policies around how we take care of patients is what needs to change more so than just the demographics alone is not a single solution. So when you think about achieving health equity, you have to look at sort of the bigger strategy here. One, what is the problem? What are the health disparities? How are you going to implement these changes and policies? A lot of my colleagues always say, I don't know why you took the time to do a health policy fellowship. If you asked me 10 years ago in residency, would I have done this? Probably not. But if we as physicians don't speak the language of the policymakers, you can't make any tangible difference for your patients or yourselves, quite frankly. And that has both a financial impact as well as a patient-reported outcomes impact. And when you're implementing some of these changes, it's important to also continually monitor the effect of those changes that you make on a small scale and large scale, and continuously reassessing those strategies. So when I start from the beginning, right, so that was the framework. How do we get started in this work is really looking at the healthcare disparities and total joint replacements. We've done same-day surgeries. We run 2 rooms. I can do a knee in 45 minutes. You're off pain meds in 24 hours. Yet the disparities that exist have not changed. So we're doing better surgery, we have better outcomes, but the actual outcomes for Black and brown patients, which has been the surrogate for disparities, and I'm hoping by the end of this talk, we're getting away from that, and we're looking at the social determinants of health, but that has not changed. So when we look at the racial and ethnic disparities that have been reported in the literature, we're seeing that more Black patients are affected by knee and hip osteoarthritis, and that prevalence is even higher in women compared to men. So it all starts with the research around healthcare disparities and knee and hip osteoarthritis. Overall, there's a lack of representation and underrepresentation in clinical trials. If anybody is a researcher in this room, you know what it takes to do research. You know what it takes to recruit patients, follow up with patients, have them even enroll in the study in the first place. And most of the hospitals, at least in Illinois, when we look at the demographics that serve the most highly vulnerable patients, there are most small hospitals, they're under-resourced and really undervalued in the state. So in that, we found across all surgical subspecialties, orthopedics being the most profound. So when we look at the systemic review of looking at all of racial and ethnic disparities, orthopedic subspecialties don't even report race and ethnicity. It's not even a requirement in most of our journals. We rarely report social determinants of health if anyone's even collecting that information. And it's actually overly represented by white patients compared to, again, the disease prevalence itself. So we looked at our clinical guidelines. We all, depending on what specialty you are in this room, we all abide by our clinical guidelines. We decided to review our American Academy of Orthopedic Surgeons guidelines as far as the methodology, who was included in these studies. It was about 211 studies that basically tell us who we should operate on. Yet 7 studies actually reported race, actually included patients that were representative of this country. So that evidence base for management is actually over-representative. And this is sort of where research can become dangerous, right? If you looked at some of the early COVID data with the pulse ox machines, they're actually underreported how much someone was actually deoxygenating because of the pigment of your skin, because patients with that pigment were not included. So there are consequences to research, and that's really what comes down to why the FDA sort of created this diversity action plan to require the clinical research is representative of the patients that it affects, right? So One, you have to understand who that disease and condition affects. And secondly, are those patients being included in your study? And what is the strategic method that you're taking to enroll these patients and keep them in your study? And lastly, PI representation matters. This is our demographics for 2023 in our group. We just updated the 2024 numbers. My population is actually 72% Black in my patient population. You can say compared to my partners. So if you're going to collaborate with other physicians, other institutions, it's really important to understand what patients are coming to which surgeons, and that greatly affects who you're going to be able to enroll. So the meat of it is, what we've been doing, no matter how great my surgery is and how well we do it, the status quo simply is not working because we're missing a whole patient population that aren't doing great surgery for. So what does the current landscape look like? So as hip and knee replacement surgeon, and it's coming for most procedures that we're utilizing now, but social determinants of health is being bundled into this value-based care model. As you can see, 80% of health outcomes is driven by social drivers, and our surgeries are very replicable. So that's why CMS sort of said, okay, we're gonna go and look at, really from a financial perspective, these high resource areas. So when we look at these social drivers of health, I see this as vital signs. We should be collecting this information, not only collecting it, but intervening on that information on every single patient, just like a vital sign that we collect. And when we look at social economic factors, it really has to do with your education status, who is in your home, do you have access to a car? And when we get to the social vulnerability index, the basis of it is really looking at these cohorts. You know, what kind of community health resources do you have access to? How much economic stability from an employment standpoint? I have to understand that some of my patients who come in don't have FMLA paperwork to hand to me to get 6 weeks off of work. That's just not the type of job they have. So who's going to put food on their table during their recovery? So it's really, as surgeons, those are the patients that we say, okay, you're really not a candidate then if you can't do the PT afterwards, or you can't ice or elevate, or you can't get the medications you need when they really do need it. So the easier way to sort of report this is through the Social Vulnerability Index, or the SVI. You may have also heard of the Area Deprivation Index. This is another area of how you can report this information. I like a lot of questions of like, which one should we be using in the health equity space? It really depends on where you are. So if you're in an area like Chicago is one of the most segregated cities in the country. It's very well delineated who's living where. You can use Area Deprivation Index from a zip code standpoint, but that may not be the case in an Atlanta or a Dallas area. So it's really understanding where you're collecting the information from, where your population is coming from, that you may not be able to rely solely on zip codes alone. So when we think from a policy standpoint, how CMS, or the Center for Care for Joint Replacement Model, started was in 2016. And the goal of this, like many policymakers, is to decrease cost, right? So if you don't think in your subspecialty they're coming after you, they're coming, right? It's just a matter of time. And what we launched in 2016 was this model to basically decrease cost. And there was some early success. We were lowering costs, decrease. Patients weren't going to SNFs or acute rehab facilities. Increased patients going home, right, which is less cost to the system. But surprise, surprise, CMS found these troubling implicit biases in 3 models: the kidney model, the cardiac model, and the total joint model. And what we find, because the models were basically framed similarly, was that these safety net hospitals were more likely to be financially penalized. So if I'm in downtown Northwestern, I've got 5, 6 different staff members working with my patients. It is not the same as going 8 miles down the road to Inglewood in the south side of Chicago with a hospital that has 50 joints a year, and you got just the surgeon really managing all of these patients. So what they found after that 5-year model is their case mix was decreasing. So they were getting less and less Medicare, Medicaid, which was their social sort of economic impact. Less of those patients were getting joint replacements. So what's coming next, right? So from a health equity lens, how is the policies changing around this? We have patient-reported outcomes. I'm not going to focus on that first one now. We're already in that. But the latter two, which is mandatory reporting of social determinants of health, as well as the transforming episode of accountability model, or called the TEAM model. So the reporting of SDOH was started as voluntary. In 2026 will become mandatory. I know here, just talking to some of the colleagues at UT Southwestern, you guys are already collecting some of the SDOH information, but it's really screening for these 5 domains, which is food insecurity, your housing insecurity, your utilities, and interpersonal safety. So why is it happening now? Again, it's a cost standpoint. Reimbursements going down for surgeons, facility fees are going up, but understanding how can we basically take two different hospital systems and make them equal, right? How are we gonna make sure that these patients aren't going to be cherry-picked by surgeons to say, oh wait, you're gonna do well, you're not gonna do well because you don't have any of these things to help you after surgery. So that's sort of the basis of where the team model is going towards. So by reporting some of the social determinants of health models and screening for some of these social drivers, you're going to be able to get information looking at the percentage of high-risk social patients and if how many of those patients in your system are screening positive. So instead of the Loretto Hospital that's 8 miles from me getting penalized because they've got a high-risk patient population, they will actually get some financial reimbursement to help take care of those patients because they're going to score positively more so than my practice. So Ron Delanois out of Baltimore has really looked at how incorporating social determinants of health in a value-based care model is happening from a health equity lens, and a lot of their intervention and screening, and again, by screening initially, you're gonna get information of what your patients are gonna be affected by, and for them mainly was food insecurity. So they've built really nutritional pathways to help patients so they have the right albumin preoperatively and postoperatively, and they have access to food and good weight loss. So when we look at the Transforming Episode Accountability Model, which is the team model, 740 hospitals have been picked, mainly out of New York, Connecticut, some of the West Coast hospitals, and two Michigan, and some of the outskirts of sort of the Illinois hospitals. We did not get picked for the team model. It eventually will get there. We're all going to be included in this. But this is actually going to include coronary artery bypass grafts, joint replacements, spinal fusion, hip fractures, and some of the major bowel procedures. And they're really looking at this mandatory episode within the first 30 days and trying to make risk adjustments around that. So around age, social risk, and making these adjustments so that surgeons, again, aren't being penalized and aren't disincentivized from taking care of patients from the most highly vulnerable areas. So when we look from a health equity strategy, the whole goal of the TEAMS model, especially safety net hospitals, is to provide better support for underserved areas by making these social risk adjustments to ensure these sort of targeted prices. But to start from a health equity model, you're not going to go anywhere without actually understanding your community. I think this is probably one of the first things any institution, any department, if you're going to be in this space, is understanding where your patients are coming from, what risk factors, what do they need, and it's really important to understand that if you're going to have good outcomes and really strategize how you communicate with these patients. This is a map of Chicago. These are the food deserts in Chicago. So where Northwestern is in downtown Chicago, Streeterville, average age life expectancy is 90. You go to Inglewood, where most of my patients live, is 60. That's a 30-year age gap, 8 miles down the road, right? So we think about these food deserts in Chicago. There's no Targets and Whole Foods, but there are food swamps. So it's not food insecurity, they're food swamps, right? There's been disinvestment into these neighborhoods to provide the higher quality of food care and the investment into those communities. And you sort of wonder, like, how did we get here, right? How did we get to going to certain neighborhoods and all you see is fast food or liquor stores or corner stores, no playgrounds? Why did this happen? And it all stems from redlining. How many people are familiar with the term redlining? All right, so this is actually the map of Dallas. Redlining was the practice in the early sort of 1935, 1940, where the federal government, it's called the Homeowners Loan Corporation, graded these areas as far as residential capacity and graded them as basically being high risk or low risk. You can probably tell if you name some of the neighborhoods today that are most at risk, they're probably coded back in 1935 as low risk. So there's huge disinvestment into these communities. So you're not going to get a Whole Foods going out there. You're not going to get a Target. You're not going to get anything of a corporate standard because that area historically was not invested in. And so when you think about the food swamps, the fact that a patient in Inglewood, the closest PT gym for them is 4 miles, right? There's no PT gyms in Inglewood. These are all areas that no one invested in because of these historical practices. So that's something that we need to start understanding from a public health lens, is that we want to do all this for a patient, but there are some structural, basically barriers to being able to do this work. So what we start to think about is like, how do we actually implement this into a health system standpoint? I led our NMH, our Northwestern Medical Health Equity from a joints perspective. How do we actually start getting this information, and then what do we do with it? So we started, like you, implementing it into Epic, and using this social determinants of health questionnaire. We had very low response rates in that first year. So I go back to that slide I showed you with strategy, constantly understanding what you need to improve on. Ours was response rate. No one was filling this out. The patients were filling out, the physicians weren't filling it out. It was becoming burdensome. So we actually put a stop gate. So if a patient comes to see me, my MA wants to put the order, we have x-ray in our office. She can't put an x-ray order in until this is filled out. You come through the ER, you want to give IV fluids, you can't put it unless it's absolutely urgent that this patient needs it. So traumas override this system. You can't put an order in without filling out this information. So now we have a 94% response rate, right? Because we all want to do our jobs, but we want to also, this is a vital sign. This is just as important as a nurse taking a blood pressure. And so when we collect this information and we see these patients who are high risk, what do you do with this information? And we've got health equity social workers. I have a social worker that was initially funded from a research grant in my office. But if you flag at risk, it automatically opens up our community partnerships. So we've built a community partnership with basically every single zone, we call it healed zip codes in the city of Chicago, where if you don't have transportation, and I know that on the front end, I have to know that, right? I collect this information. We actually have partnered with PT gyms who will come pick you up. We've partnered with home health agencies who will give you an extra week of PT at home because you can't get at home. If you have a food insecurity where you can't get the right food after surgery, we've got community partners from a delivery service. So we've gone out to the communities, it automatically flags, there's no extra burden on the physician to send that information out, plus we have the social workers. So it's a lot of care coordination. My team is quite large and requires bodies. So what I always disclose here at this point is the way Northwestern has done it is not scalable. It's absolutely not scalable. If I went to Antonia Chen, Department Chair of Ortho, and I said, hey, I need a social worker, 2 nurse navigators, an MA, she's gonna look at me and laugh at me, because she's like, who's paying for that, right? And living off of research grants is not a sustainable outlook, because this is a mandated thing that we need to do. So this complex care pathway sort of confuse patients and really will burn out physicians. When I talk to my partners about collecting PROMs, collecting social determinants of health, it's another burdensome thing that we already have a lot of physician burnout. I saw this LinkedIn post that I think spoke to me in that moment, was sometimes I feel more like a clerical worker than a surgeon, right? How much time we all spend on Epic, right? Messaging, filling out orders, filling out medications, and really where I think the future needs to go is innovation. So Christian Payan, he is the CEO of Rebel AI. He's a trauma surgeon. He was actually my medical student many years ago. He's now a Duke trauma surgeon. So throwing it out there, your mentee-mentor relationships, you may end up in a business together 10 years later. But we sort of started looking at how do we do social determinants of health better and collecting this information without feeling like this on a daily basis. And so we have, in the last 3 years, launched this AI pathway of really creating these AI agents to basically interact with patients and coordinating social determinants of health. And instead of my social worker making all of these phone calls, it's this AI agent. With health AI genetics, genetics, I should say, it's really understanding 3 things from an AI agent. And if you're going to delve into this sort of innovative space, is it has to observe your environment. So we build it into the system first to understand what is the practice habits of every physician, right? What do I typically say? What does my PA typically respond? And then building in some protocols, as well as visually doing co-pilots, right? Actively engaging with patients with a barrier of having a nurse still viewing what's actually coming in and coming out. And then why this health AI agent actually matters is really getting a better streamlined approach, making it less burdensome for physicians, and having more direct contact with patients. So what we've looked at is a sort of text-based system. It's built into the system with an AI automated workflow. And it's basically appless engagement. It's text messages, a patient can text message you. This is just an example of what that care pathway sort of looks like. And getting a welcome message, and then it pulls information. So if a patient's already talked to their PCP in another visit that I have food insecurity, it's already pulled that information for me to see in my visit, so we're not spending more time trying to collect that information. And basically what this AI-driven care coordination and what we're trying to move forward towards is really keeping the teams alert as to what's going on with patients and getting more touch points with patients. This is just an example. A patient's called in, they need a refill of their medication, and they're having some questions about their wound drainage.
Hello, this is Dr. Suleiman reaching out. I wanted to let you know that your pain medication has been refilled and sent to the pharmacy.
So this
We've
is
also received the pictures of your
Yeah,
wound that you sent through Reveleye,
never
and
said
we'll be
these
reviewing
words.
them shortly.
Responding back.
Hola, soy el Dr. Suleiman. Quería informarle de que su medicación para el dolor ha sido rellenada y enviada a la farmacia. También hemos recibido.
So these are just ways for us that we're trying to create better touch points, but using innovation instead of relying on people to be able to do this. Because it's, again, we're thinking from a scalable standpoint, how do we make this happen from a patient perspective and physician perspective? And then lastly is really understanding the financial aspects. When you think about all the work we're doing on the pre-op end, these are CPT codes we use for billing. It helps fund part of our social workers' salary. And so we look at all that billing. It actually bills for a social worker and a half each year. And that's just out of my own practice. And then, looking at the future, like what can we do to make this simplified, and where we've sort of gone with the sort of AI intelligence is creating these guardrails, making this a narrow clinical focus, and really generating good information, as well as connecting them with that information with the community members and the resources that they need. And so instead of, again, a social worker calling that PT gym to say, hey, this patient is deemed at risk for transportation, we're going to need it 3 weeks post-op, it's already generated and done electronically for that patient. We've had a great start over the last 3 years. These are the health systems that we've partnered with that have implemented it, some corporate partners and strategic advisors. And it's just a very cool space to try to do this work, make it efficient, and make it better for patients. And I think innovation is going to be the future in some way, shape, or form. I don't know if this is going to work. It's just sort of the second phase of my life that I've been interested in using innovation for social work. But really, the point I have in all of this is that if you look at all the disparities data that we've published, and you can name cardiovascular, neurology, ortho, whatever it is, we've had such a focus on race and ethnicity that we've missed sort of the structural issues that really facilitate these observed differences, right? And that's the social determinants of health piece, is that those are the social drivers that are driving these differences. And the difference in the solution for knowledge improvement should be handing out more patient flyers is not going to be it. But that understanding that education and socioeconomic status is a product of these entrenched mechanisms that are really rooted in power and privilege. So in conclusion, I think successful transformation is delivering equitable care. It's disruptive, it's continuous, it's exhausting. This is not easy work, but it's definitely worthwhile, and I think a moral imperative for all of us as clinicians in this room. And I think any trainee that's in this room, really leverage your passion. The world is your oyster, and you can make this change happen. Thank you. Yeah.
So we have time for questions on both sides of the room. We have microphones positioned. If you'll just raise your hand, I'd be happy to host any questions.
Thank you, Dr. Suleiman, for a fantastic talk. As an orthopedic surgeon, I, of course, appreciate the orthopedic references that you made there. But obviously, orthopedics is not the only thing here at UT Southwestern. How can we implement this across a huge, broad healthcare system where we all have different similar patient populations sometimes, but different conditions? How can we do that in psychiatry, in orthopedics, in cardiac, and internal medicine, and make it so that it's fluid across the system?
Sure. I mean, I think first and foremost, what I learned this morning, that you guys were collecting it, and most people didn't know you were even collecting this information. So one is, there's not a soul at Northwestern that doesn't know, because it's in your face, right? So one is making sure that everybody knows that this is standard of care and practice at UT Southwestern. I think it has to start there from the top down. Second, I would say is, instead of basically doing something new in each different department, is collaboration, right? And so if our psychiatry colleague has a community partner that does X, Y, and Z, we should all know about that community partner, and it should be built in. Another system that we did for several years was something called NowPow. It automatically generates these referrals and inputs to those community centers. And that's been pretty successful. But again, you have to build those community partners. So the initial task force that we created was across all of the departments, including not just the clinical ones. We included nursing, we included public health, preventative health, medical social sciences, and it was all of these people to get different perspectives, as well as our community arm of Northwestern. We have an entire community engagement arm, and it sounds like at Parkland, at least, there's a lot of talk about really a high level of community engagement. And so you gotta come into one brain trust at the beginning. You already have it built into Epic. That's the hardest part, honestly. So whoever did that, kudos to you. That's a very expensive process. Is now, what do you do with that information? And is everybody collecting it? And I do think at some point it has to be coming from the record. We're documenting it in our notes. I'll probably covering all of the social determinants of health. It's just a matter of how you collect that information out of notes to implement it into an SVI score. Yes, ma'am.
Thank you for a terrific talk, Dr. Suleiman. I'm a professor in the School of Public Health. I'm very interested to hear about the AI applications, and particularly appreciated your reference to value-based care and some of the purpose of a lot of this. So that's useful to me, and that's inspiring part of what I'm asking. Could you talk just briefly about any of the feedback that has come to you, either through the AI interventions or through other portions of what you've described, feedback that has changed the system or changed arthroscopic surgery? Or I know you did some work in opioid use. Did you get any information from patients that then changed the system?
Yeah, so we actually changed, opioid was a big one. The number of medication refills that we were just like missing because it was coming in, we didn't know when that was happening. So a lot of the feedback we've gotten from the AI generation, it's flagging us to these problems early. So we actually changed our multimodal pain modality. We're actually now using it because we're seeing a big disparity in outpatient joint replacements. So joint replacements has been taken off of the inpatient only list, meaning that it's a 23-hour OBS or you're going home the same day. And so again, surgeons are saying, okay, are you able to go home that same day? Who's gonna take care of you? Who's gonna pick you up? Who's gonna deliver food to you? And so we're right now trying to change who we deem as an outpatient candidate, because we are on the front end creating the resources they need to go home the same day. So that's the biggest thing we've seen in 2024, because embarrassingly, what I saw in 22, 23 was a decrease in the number of outpatient surgeries for those who were deemed higher SVI scores. We were just seeing them in clinic and saying, oh, it's gonna be too much for you. And then some of them weren't getting surgery because their insurance would not pay for anything but outpatient. So I think that's where we're moving forward for 24, 25, is that we're not cherry picking people to say you're a candidate or you're not a candidate based off your social situation. I did joint replacement on a patient who was undomiciled, but we were able to give him a home that then transitioned to a care home. But that started with our screening process in a joints clinic, right? That shouldn't happen in a joints clinic. But again, it comes from what's the resource there and how we connect folks in the community to be able to start that.
Thank you for the great talk. So kind of alluding to what you just said there, I guess one of my concerns would be, front and center as soon as you open Epic, this SVI score for each patient, all of a sudden categorizes patients as the ones who have the high scores who, may be in the hospital because they're pain seeking or, because they're poor and Black and all these other things. And I start worrying about whether that already, from the beginning of somebody opening the chart, any number of providers, from the nursing staff to the physicians to everybody who's taking care of the patient, kind of starts sort of having that sort of thinking of this patient is this type of patient. And I just wonder, how do you overcome that, where that score reflects we need to help this person a little bit more or a little bit differently in a positive way, versus really elicits the biases that all of us have gotten from the training that we've had, which is in fact very kind of biased in how we've all been trained through medical school?
That's a great question. Actually, we saw the first impact of that on the patient side. So I'd have patients come in and I'm like, why don't you want to answer these questions? Like my MA would say, they don't want to answer the questions. And they were so nervous that I would not operate on them because I knew they didn't have a car, or they didn't have food, or something that they would deem sort of at risk. And they found these questions to be sort of very overly personal. And it was a lot of like, well, why are you asking me this? And so it took a lot of education on the front end. So we actually send like text from the beginning when you make an appointment with me that you're going to have these questions and this is why. And it's actually surprising how many patients actually read that information. Now on the clinician side, again, we've done a lot of education from the nursing level, the physician level, to basically help people understand like this is not for us to tell someone they can't have surgery, first and foremost. This is for us to do surgery better. And so it's changing the narrative with individuals on the front end. So as soon as someone gets hired in our division, whether it's pre-op, post-op, in our outpatient clinics, they understand this is why we are collecting this information. And so we've sort of changed the narrative. I haven't been able to measure what that bias has looked like. If you have a great idea of how to do that study, I'm always up for it. But it's really the education and the conversation from the beginning.
So I have a question about, like, first of all, the education that you mentioned. I think it's critical to actually reach to different communities, but it's a concern about like the costs of like, now you know this information about what are the needs of this person, but then how are you going to really help, for example, cases of, in Texas, we have a lot of immigrant population. And under non-documented immigrant population. So each day that they don't work is a day that they don't have food, basically, right? And most of these people also send food to, or send money to their families abroad. So, so they wait probably till the very, very last minute to have any of these interventions because of the consequences that comes with. So once you know this information, how do you deal with it? What are the resources? Like how much resources you have, and is that like a lot of money? Like how is it? How reasonable is it?
So we are a safe state in Illinois. So it is different than in Texas, where we have hospital funding for patients who are undocumented, and it's specifically through county care. So Cook County Hospital does have a certain budgetary format for patients who are undocumented. Here, I don't know how I would be able to solve that with the legislature, but I think the biggest thing is the elective versus, maintenance of health care, right? So joint replacement's an elective surgery. No one's going to die from knee and hip arthritis, but I do believe functionally it's going to be able to make you walk and work and do the things you need to do to stay healthy. I do think that from that standpoint, we have to make sure that there's not this fear to at least disclose that information. And it sounds like you don't even have to answer the question from the laws that I've read here, but that's going to be the hardest hurdle, and that's a population I have not figured out.
Thank you for the great talk. So we're early in our careers, so we're first and second year medical students.
So you're telling me you're future orthopedic surgeons?
Potentially. But I think one of the other question askers alluded to this idea that we don't have a lot of control of our education right now in the context of like how we learn about the social determinants of health and how we incorporate that into our clinical practice. Like, giving a patient or taking a patient history, like how do we ask those questions? Very simple, like foundational skills a physician needs to learn. My question is is there anything we can actively do at this stage in our careers to think more critically about that aspect of patient care?
Yeah, so the AAMC actually has a really nice equity series, and it's actually from the education lens, and they do it every quarter. And they basically they're free webinars online, and it just talks about patient interactions, how you take care of patients from an equitable lens, and they're each sort of focused differently. We did that with our medical students, our first year and second year medical students a couple of years ago, and now we put it into like our standardized patient interactions and curriculum. So if it's not built into your curriculum, I will say there's a lot of really good resources within the AAMC if you just search on their website, health equity strategies, of actually watching videos of how do you talk to patients, how do you collect this information, just even our body language, right? Coming from a safe space and not coming from like interrogating you sort of mentality. And the thing that we don't do well as physicians is tell patients the why, which is the biggest thing I learned out of that series is why am I asking you this, right? And starting there before even asking the question. So that's, I think, a good place to start. Thank you. Well, thank you for the great questions.
I have one final question. We've heard a lot recently about insurance companies denying people to have surgery based on their anesthesia, not allowing them to have coverage for anesthesia, so then they don't get the surgery, whatever it may be, which drives me to ask, how do you see this affecting insurers' responses to having the SVI or the vulnerable index being, a part of the medical record?
Yeah, so the one thing I've noticed a change, at least with Blue Cross Blue Shield Illinois, so Derek Robinson, he's a Black male, internal medicine trained, he's actually their chief medical officer for Illinois. And we've met with him at least every quarter over the last couple of years, and really, we know what Medicare stands and what we need to collect and why they're collecting, but we haven't had real conversations with commercial payers. What I'm getting from commercial payers is that having this information, they're doing a lot more front-end work on prevention, right? So, for example, January 1st, I switched to Blue Cross Blue Shield. You put in your information. They want to collect this information. Like, do you have access to food? They're actually collecting it on your new patient, like if you're starting a new insurance thing. And they're actually doing it with renewals. They're actually giving you a discount on your insurance policy at Northwestern if you fill it out. So Northwestern employees, you can do Aetna or Blue Cross Blue Shield. And I sort of asked Derek, why are you collecting this information? And they're actually, so they sent me a scale. Like, they sent you a blood pressure cuff. They're sending you things to try to help with your overall health if you're deemed risk at these time points. And then they're actually having nurse navigators call you. So they're seeing it from a cost containment standpoint, that if I know that you can't get good food, which is contributing to your diabetes, I'm gonna send you a weight loss specialist, a coach, here's an app, so I can decrease my cost of your admissions for your diabetic ketoacidosis. So I've actually seen from the commercial side, they've actually been doing this much earlier than CMS has been doing.
That's amazing to hear. Any final questions? Well, thank you so much, Dr. Suleiman, for joining us today.
Thank you so much for having me.
We have a small token of our appreciation.
Thank you.
For making the trip from Chicago to Dallas, and we hope that you'll come back and spend a little more time with us, maybe. But
Antonia, she's asking you to offer me a job.
But this has been a phenomenal way for us to kick off our series. We are happy that all of you who are present have chosen to join us. We ask that you stick with us. We've got 4 more fantastic lectures. If you like this one, you're going to love the next 4 of them. There will be, the next talk is February 21st. Dr. Lorna McNeil will join us from Houston, speaking about cancer disparities as a part of a retreat that's happening with our Simmons Cancer Center. We partnered with them, and then several more to follow. Thank you all, and have a fantastic afternoon.
Thank you. And just one final plug, because I'm a shameless plugger. Antonia and I are heading to Tanzania in 2 weeks. We have a nonprofit called Women's Orthopedic Global Outreach. We do knee replacements. We take 2 medical students and 2 residents. I didn't get any applications from UT Southwestern. Would love to see an application next year, if you'd like to join us. Thank you so much. Thank you. Had a really fun time.